We're going to finish up the skin, but first, now this is not only the study side, it's very useful handout. What's going to be has major structures that are going to get bones practical. Start this bones even today. I'm thinking either week 5, 2 weeks from now, probably week 6. Whatever that is, calendar. I mean, probably not the week of the 26th, but the week after. I'm trying to figure it out. So it'll either be Monday the 20th, probably Monday the 29th. Okay? I think that's when we'll do this practice. Nevertheless, lucky you. So so we're going to finish up the skin. I have that model. It's somewhat useful. We just have to do skin cancer rule of 9s. And we'll dedicate the rest of the time to bones. I'll acquaint you with the bones. We'll hopefully get through some of the skull, preferably all of the skull, if all possible. And that should be plenty for today. Drink for Monday football, but I conked out. I gave it. Yeah. You could have bet good money that the Steeler game would have been the game of the week on any other week, except for that miracle. So, nevertheless, here we go. You watch football? You don't seem very enthusiastic. Thank goodness. Just stop by. We talk football in the morning, Dr. Buxton and I, but it's one with you. Soccer, nothing to talk about this week. International break, nothing going on. Except the U.S. team getting tortured again. God, they're terrible. All right, so this is where we left off. I've taken all courses in dermatology. If you have questions in general about dermatology, I'm happy to answer them as much as I can. Diagnosis is complicated. Treatment is fairly straightforward. For my years doing a ton of, and in my field, when you do feet, it's bacterial and fungal and viral infections all over the place. You're very, very used to that. So, and I prided myself on being pretty good with this stuff. These are very significant. There are basically three types of skin cancer. And in the old days, 3 degrees of burns. That's really what's left. We'll do this. Look, the most recent study I read was that 1 of 3 of us during our lifetime is going to get some kind of cancer. The vast majority of the people who get that kind of cancer are going to be skin cancer, and it's going to be the kind of this basal cell carcinoma, the one that you don't have to go home and sweat about. Okay, all I have to do is remove. Very common, again, your ultraviolet radiation, irritation is almost always on exposed surfaces, typically on the face, neck, clothing, collars, glasses, pick something. Nose guards and glasses, that's where you see this stuff. All the time. I said it before, be cautious. Read the current research on using various kinds of, ultraviolet blockers, all these FPF. Please be careful with your exposure to this. I know people like to do that. I usually joke about it in class. It's not that funny. My daughter, for years, I'd give her a call when I was starting to teach this. My daughter's going to be 40. 20 plus years ago. Oh, hi, Dad, I can't talk. I'm tanning. I was getting her bathing suit season. I want to have a tan ready to go. She's in those things. Okay. Maybe she does it less now. I don't know. So, nevertheless, the 3 major types, basal cell, typically in the areas that are exposed. Squamous, no different. And then what diagnosis you don't want to have, melanoma. Those are the 3 majors that are there. So in order of significance, this is the least significant. If you want to think of it from a standpoint of causing you potentially being life-threatening problems, to one that is certainly associated with life-threatening problems. Least malignant and most common. Basal tells you where it is, basal. Proliferates very slowly. Yes, it can be invasive. 99% of the cases, removal. Are there cosmetic implications? That's the location for sure. That's why, dermatological surgeons know what they're doing. There's a lot of dermatological surgeons who do a lot of plastic surgery. There's an overlap between plastic surgeon and dermatological plastic surgeons. They do a lot. They do hair implants for men, and a variety of types of things. There's a lot of duplication in there, and not to say a lot of competition between those two. So get somebody who's well reviewed and has good recommendations if you do have to go through something like that. So that's really what it is. They always show you this one on the nose. This thing I got over here that was probably had a little, I wouldn't be shocked if it was a basal cell. I don't go out in the sun much at all. It's just that time of life where you get them. Okay, my dad had one removed when he was maybe in this age. We used to go to the dermatologist. Oh, he burned them off. He said they're fine, just skin cancer. Okay, Dad. Squamous cell. The problem is it requires aftercare. It can and will, with the big problem, metastasize. The word tells it all. Stasis is staying. Meta is beyond. Metastasis means it's beyond staying in one place. It spreads. And if it spreads, there are problems. It can spread anywhere. Typically, as you'll learn about when we talk about cancers as time goes on, there are predictable patterns to look at. Okay? I mean, if you're thinking about breast cancer and prostate cancer, and everybody should be, I mean, one of the places you look at if it starts spreading is bone. That's a frequent visitor. So you learn, people in medicine learn right away, doctors learn right away. It's not just the cancer. Where is it likely to go if there's evidence that it's spread based on the biopsy? And that's what you do with these things. When you remove them, you try to see, you always remove them with enough surrounding tissue because it's the interface between the cancer and the surrounding tissue that gives you an idea of what's happening. Like with my bladder cancer. That section showed whether it had invaded. If it had gotten into muscle, I would have been in trouble. And say it's unlikely I'd be giving this lecture. Not necessarily that I wouldn't be around, but probably would have a difficult time teaching. Okay? It involves keratinocytes, now stratum spinosum. So the next layer, as it moves farther away, scaly reddened, scalp, ears, again, exposed area, radiation therapy, removed surgically, usually a combination. But those that when you have to do that kind of thing, now radiation therapy has its own subset of problems that are associated with it. There's a recovery period. And they always show you this picture. You can see its scalp. If it looks irregular, and that's what you look for. I was telling you about with the Polaroid and things like that. If you're going to, and that's the good thing about being with a family doctor or with a family practice who does things like that, particularly as you get older. Make sure that they're marking it down. They're taking images of those things so they can follow. They're willing to. It's not easy to get into a dermatologist for something routine. It is not. Oh, we can see you in 3 months. Damn. That's when your family doctor gets in and goes, hey, this needs to be seen now. This is melanocyte cancer. Most dangerous, highly metastatic. If you see it, it's probably already metastasized. Resistant to chemotherapy. Wide surgical incision, immunotherapy. You're trying to bolster it. We have tried everything. It was the original child of immunotherapy, a very famous doctor out of National Institute of Health outside D.C. His name escapes me. This is good 40 or 50 years ago. He learned to take where it metastasized, he would pull out the metastases, he would pull the white blood cells that were attacking it out. He would remove them chemically, he would grow them in culture. He'd remove them, he'd grow them in culture, he'd bolster them with agents that would enhance their powers and re-inject them. That was the earliest type of immunotherapy. He was really a pioneer. It didn't always work, but he was a pioneer in that particular idea. It's just not a good diagnosis to have. So if you're watching football on TV on CBS, who do you see? Bill Cowher. Bill, if you did not know, when he came here in 92, I'm going to tell you now how old they would be. I'll bet you his oldest was probably in grade school at that time. How do I know that? Because my daughter and his eldest, he had 3 girls. Rivals is the wrong term. They were both very pretty blonde girls, and they kind of tried to outdo each other, that kind of thing. High school stuff, and Fox Chapel schools. So there were two other girls. We'd see them. We'd see them at Kennywood Day because it was off season, all that stuff. Just regular, normal people. And his wife Kay, everybody in the high school knew she was always there. She was always helping. If it was a project, if they needed a volunteer, she was there. So they knew her by name. For a variety of reasons. One of the reasons he left coaching and went down to North Carolina. Not to say they didn't have difficulty in marriages, everybody does. Is she had developed melanoma, and about 2 years later had succumbed to it. They met at NC State, where they both went to school. She was a basketball player. Her girls were very good basketball players. So they went down and played. She succumbed to melanoma. And that's one of the reasons he left coaching, and then eventually made his way back into the broadcast booth, where he's obviously a fiction. But, basically a Yinzer through and through. I'm an adopted Yinzer. So I just want to make fun of all the terms. I told you, my wife has, on the wall, she has vessels that carry water, pitchers. They're Yinzer. Bellevue. So, and they call it the ABC deal. Well, if you want to talk about that, the symmetry, body's about symmetry. Anything that changes, size, shape, texture, color, any of those kinds of things, irregularities in the border, color, if it's larger. The only thing that excuses from being unusual is if a hair grows through it, because hair grows on skin. That's not abnormal. Other than that, you watch those, any of these quote unquote pigmented lesions. So it may just be a freckle or a mole, but you've got to look at it. If drainage comes through it, that's not a good sign at all, unless there's been something traumatic. I got scratched or cut, that type of thing. That's where it is. I mean, you see something like that, you're scared. That's something that is terrible, terrible. People when they discover things like that are not going to survive. I guess they talk about, if you did not know with cancers, they talk about 2-year and 5-year survival rates. So let's say a 5-year survival rate after diagnosis would be less than 50%. Same thing with lung cancer. If you have certain types, it means half the people after they are diagnosed, not necessarily when they contracted it or developed, are gone. I mean, you have to use, if you're going into a healthcare field, everybody, remember, in life, rule number 1, people die. Rule number 2, despite our best efforts, go back to rule number 1. It's not easy. Okay, which brings us to the last topic, which is burns in this little subunit. My son called me. He's driving to Norfolk. What fun. You think they know my schedule? So, anything. A burn is a very interesting term. We associate burns with heat. Thermal injuries is a better way to describe burns. The worst complication from a burn, since I don't get you for micro, that I ever heard about, and I had seen the patient, but I graduated from my residency and went to private practice, was a man with frostbite. That is a burn. It's a thermal injury. He eventually, it was a failure of everybody who saw or had any hand on that chart. No question about it. Homeless individual. They had, how they wear the gloves with the fingers have already gone out, whatever they could find. All those fingers were terribly frostbitten. They had to amputate his fingers. Nobody thought to give him tetanus prophylaxis. That's anaerobic, that's dead tissue. Tetanus grows in dead stuff. So put that in your memory bank. If you're ever in a clinical field, someone has frostbite, you don't have a reliable tetanus history, make sure they get tetanus prophylaxis. Period. He went through the terrible thing that tetanus is untreatable. Okay, that's a thermal injury. Okay, so death of tissue from alteration in temperature, necrosis, death of tissue. So all of these things are possible. Denatures the proteins, destroys cells. In most instances, the big problem are 2, and they're equal. Infection, loss of fluid and electrolytes. We studied the skin. I told you, what happens in a, quote, second-degree burn, we know it because it blisters. Blisters break. Even if they don't break, the fluid is lost. And eventually they'll break and it will be lost. It doesn't get reabsorbed. And so after you have a certain amount of these, it can lead to just this. Even, they don't have to be 3rd-degree burns. They can be 2nd-degree burns because your kidney has one excuse. One thing it does when things go wrong. If there's not enough circulation, if there's infection, if there's trauma, it shuts down. This just gives it an excuse, shuts down a circulatory shock. So we classify them now as partial and full thickness. Partial implies epidermis only, or superficial dermis and dermis. Full thickness implies deep dermis. So in the old days, like this is the diffusion wall throughout the partial thickness epidermis into the superficial dermis. You can see the top of the hair follicle here. Okay, you're not going to scrub. Doesn't mean that by in and of itself we're covered with these, we're still there. Now here you can see full thickness. Full thickness is very unusual. It hurts initially and it stops. The reason is all those nerves are gone. Like, oh, it can't be that bad. It's not going to equate pain with it being bad. And in reality, after that initial horrifying pain, it's like, it's bad. No. Burns are supposed to hurt and stay hurting for a while. And that's why I like this. I like the clinical stuff that they put in with this and good illustrations. I'll do rule of 9s in a second. The big threat, I'll buy. Immediate threat, dehydration, electrolyte imbalance. Now, after that threat, after not initial, but thereafter, infection. Again, burns get infected. Pseudomonas loves that stuff. Here we'll do the rule of 9s, and that estimates fluid loss because it's a criteria for burn centers. The fact that somebody has a burn doesn't necessarily qualify them to get into a burn center. And that's important. We have 2 wonderful burn centers unless they change them in this area. Anybody know where they are? One's in the UPMC, one is in HGH. UPMC, I swear to you, acquired Mercy for the burn center. Mercy was a separate one. The other is West Bend. Bennett Burn Center for a very long time. I knew the doctors. First White knew the doctor very well. The 2 doctors who were in charge of that. They both went to, if you're familiar with Pittsburgh, they were both into the open, like she did, and her brother did. And people, the old people already high now. Down East End. Nevertheless, 1st degree, as you can see, localized redness, swelling, pain. We've all get sunburn, burn from something in the stove. 2nd degree, blisters appear. Partial thickness is a more appropriate term. 3rd degree, full thickness. Skin discolors, any kind of color. No edema is seen. The area is not painful because the air vettings are destroyed. And the problem is, unless it's just something pinpoint, something like a hot poker fell and caught my skin, oh my God. Other than that, most likely you're going to have to deal with skin grafting or something. And that's a lot of stuff, the way we do that type of stuff. You have to really deal. Burns are a real interesting problem to contend with. There are good pictures of, first, just the fingertips. You can see here. 2nd, with the blistering and nude. You can see fat tissue is starting to basically melt. You see something like that, it's, oh my God. Very, very difficult. So critical, 25% of the body is 2nd degree, 10% 3rd degree. Face, hands, feet, genitalia already are considered critical. That means that first you can't send, the emergency room starts sending patients to a burn center that shouldn't be there. If they don't want to deal with them, they're going to be good. That's called overutilization. So it's not that a physician, I think that's about 32%. You can't do that. You can't estimate. That's what the rule of 9's been around for. Stick figure, face, just for argument's sake, just make a relatively short torso. Okay. Divided into sections of 9s. Face, head area, face, whatever skin's exposed there, 9. The total of each upper extremity is 9. So you can judge before, it includes the extremities, 4.5 and 4.5. So So that's 3 nines that are there. The deep place is the torso. You want to divide it by the diaphragm here, divide it by the umbilicus. You have 9 and 9 anterior, 9 and 9 posterior. Now you have 1, 2, 3, 4, 5, 6 nines. You have the upper extremity is 27, 36 there, 36 there, 63. That's 7 nines. All right, I'm wrong. And then the lower extremity, you have 9 and 9. So you could be, you want to do it this way, 4.5, 4.5, 4.5, 4.5. If you add those guys up, that's 18 on this side and 18 on this side. Between 63 and 36, 99. And for the genitalia, pretty straight when you find it anywhere. And that's how they do the estimate if you didn't know. And so that's, and again, things, if it's children, babies, unfortunately, anything like that, the criteria are relaxed. Hands and feet, because when they start to scar, now you start worrying about digits having to come together. You have to do reconstruct. It's not easy. I have separated digits. You have to do, and it's a skin flap rotational procedure. I'm still trying to get my stock here. You should use it for that. Yeah. Just poke fun at me again. I haven't talked to her more than since May. Right away, get it. 25% of the body have second-degree burns, if you estimate, third-degree burns, face, hands, feet, and they don't include the issue. Anything in the anal-genital area is probably going to be it. How do we do it? Breathe, to breathe. All that is painful as hell. A lot of times we medicate people, you give them morphine when they come to the ER. That stuff's going to get infected, it's going to slough anyway, get the heck off. Some type of topical stuff. Topical treatment for burns hasn't changed. Don't say in medicine. There's one best thing we all use. Zolpidem cream. A combination of silver, metals are antibacterial, and a sulfur. If you ask you about it, it's good to know Zolpidem cream is wonderful stuff. Burn. I mean, you're not going to, if infection is there, it's not going to treat the topical agents. Don't. If you're good at prevention, they're not going to treat antibiotics. Or intravenously, we use antibiotics for this, covering, there's a lot of creative techniques in skin grafts. And so that's when you start to hear about when you talk about skin. Split, and it's sort of like this. Yeah, split thickness and full thickness grafts. So split thickness are very, very thin. They're basically epidermis and endodermis. You can make it thinner or thicker. Full thickness means you're basically taking deep dermis, probably having some deep. I did those flaps that were full thickness. So there's a whole science behind it. It's very, very sophisticated out. Everybody, qualify my knowledge. Last time I operated on somebody was 25 years ago. So I mean, I probably wouldn't even recognize the interior of an O. The only time I've been in there has been on the business end. Never good. I've seen this before. I just tell them, when they're giving me the stuff that puts you under, just let me have to, to be like I was in college. Just listen to music. Enjoy the drugs. Statute of limitations. Don't. She's writing this down. Here we are. So you can take a look at all that was, and that's it. Burns are really crazy. Craziest night I ever had in an emergency room with burns on Christmas night. Flop house. That's where homeless people go for, at that time, for 50 cents or $1 a night to have a bed. Reason why. We were doing nothing. It was crickets. Couldn't hear anything. We had maybe 3 patients. And all of a sudden, about 6 in the evening, and that's it's long before electronic telecommunications, the red phone, the ring, police is going, this is a disaster. Flop house went up in fire, they had 100 homeless individuals. We're sending a bunch of, to your hospital, it's 2 blocks away. Sending the others to St. Pitt, we're trying to get the others to Hahn, and these are all hospitals. And this is in North Philadelphia. We had conservatively 50 patients in various stages of severe second and third degree burns, all with smoke inhalation. There was 2 in ER and then 2 later in ICU. We were debriding stuff. That's when I learned to put in IVs. Everybody got wide bore IV on either side. Boom, boom, like that. I did blood gases for the first time. I didn't have that neat little finger thing. For pulse ox, no, you do arterial stents. Everybody would get arterial blood gases, single oxygen. We're everything. We're debriding, we're starting wide bore IVs to replace the fluids, because we have fluid electrolyte loss. We're peeling clothes and stuff off, and these are homeless people, we don't even think about it. Horrible. Red Cross came in about 8, 9 o'clock, found out how many people they were, looked around. By midnight, a truck from Red Cross pulled up with clothes. You and I would have gotten it about those clothes. We would have got the big winter jacket, pants, and gloves, and hat. Absolutely true story. Craziest night. I mean, I think I ended up going, I must have been there for 12 to 15 hours. My wife was she was certainly, the charge nurse then. She was the assistant head nurse, my wife at the time. We always volunteered for Christmas because everybody else, we're Jewish. Everybody else could have a good time. Good eats, everybody brings in good stuff to eat. It's just like in the movies. 6 o'clock, the next thing you know, it's 2 in the morning, and you have no idea what the time is. Then you remember, gee, I ought to go to the bathroom. So for those of you going into the medical fields, this is where it's from. True life stories. Okay, we're on my favorite topic. This is chapter 6. We just talks about some basics of bones. Chapter 7 has 3 PowerPoints, A, B, and C. A and B involve appendicular skeleton, axial skeleton rather, head, neck, torso. The last PowerPoint involves the extremities and the connector. We do it all. If it should be, and if not, I will do it. Would you like me to do it now before we proceed? I'm good. No one's perfect. I thought maybe I'd upload. Did I F up?
I don't see it.
This is why I want. Ay, gewalt. Yiddish expression for what a PIA. Content, you got to get back because I was stealing this. I don't want anybody to know me. Thank you for telling me. I appreciate that. I joke. Everybody, I joke around with everybody. If I tease somebody, if you don't like me doing that stuff, just tell me, shut up. Please don't do that. The other one we'll do as well. If the Steelers, however, lose, do not say that. I'll be less than happy. Well, I'll end up with 6B as well. It only takes a minute or two. This is fine. And we're viewing. Visible to student, that would be you. I'll just get 2 because we're only going to do 2 of these today, all right? We'll get the rest of those all down. It's not that hard with Ultra. It works pretty well. Okay, all good? Great. Visible to students. quickly, because this is a chapter, this is what we'll be doing in lecture on Wednesday. Again, remember, I'm not going to be here on Friday. I'm sure I'll send you some type of recorded information. If you want to email me about anything, that's fine. I just don't know when I'm going to be able to get to it. Because I'm not sure I'm going to have anything terribly reliable from a standpoint of internet or Wi-Fi consistently. It's the kind of type of thing, if my wife and I are in the car because we have to be away, that we might periodically be able to answer something. Okay, so bone and skeletal tissue working effectively with patient bone. Okay, we made out of cartilage to start. This is like dovetails into the different kinds of cartilages we deal with. Effectively, much of the skeleton comes directly from a frame of hyaline cartilage. What happens after it changes to bone, the ends, the cartilage remains because that permits motion. That's like a smooth, relatively thin portion on the top and bottom, if you want to think about that, on the wherever the areas where it will contact another bone and facilitate movement. Whether the movement is, what type of movement depends on the shape and how it's arranged. That's really what it's like. There are other areas where there's other cartilages involved. Remember, we talked about that a little bit. Your ear, your epiglottis, or the other ones with elastic cartilage. Fibrocartilage is more when we get to joints, particularly the menisci of the knee, temporomandibular joint, sternoclavicular joint, also the symphysis pubis, and perhaps most importantly, the cartilaginous pads, which are between the vertebrae, which are really important because it's from them. It's not so much the bone deteriorates, but when you hear about a slip disc, it's slipping out of that cartilage and cartilaginous enclosure, as you will learn, but probably not until next time. Continues to consist primarily of water, no blood vessels or nerves. I'll say it again, when the blood vessels invade, that's when cartilage deteriorates. Scientifically, in our case, developmentally to become bone. However, other than that, when it hits cartilage, like bleeding into a joint from a sports injury, that's when we end up with lots and lots of problems. And this is a wonderful time to look at this stuff, particularly to the extremities, which will be next week. And all the myriad, it's a great time, not good for the people who get the injuries. You just start to see those things. We saw the Steeler game with their safety. His name is on the tip of my tongue, who played so well. The guy who came back in for him played well. His cleats jammed, and all of a sudden his knee flexed inwardly. I was looking today to see if there was an update. I mean, that looked a whole lot. If he's lucky, it's an MCL sprain. Lateral. He's not. That's a quick ACL. What happened is his cleat stuck. He got rolled into. Might have been friendly fire. And oops. A lot of these, when something gets stuck, and it's a lot less common in turf. When they had AstroTurf in all these stadia, oh my God. We had ours. It was like playing on concrete. So many knee injuries. That's the old Three Rivers. Philadelphia had Veterans Field. Cincinnati, whatever the name of their ballpark was, at St. Louis's Field. Okay, they were all cookie cutter fields, very symmetrical. Injuries galore. Reflected the heat, hot summer days, brutal. Not good places to see ball games. So, perichondrium. Again, all tissue is surrounded by a dense connective tissue enclosure to help it hold its shape. So a girdle is a very, very good representation of something that surrounds it and holds its shape. Okay? Resisting expanding when it shouldn't be. That dense fibrous material, eventually, as it becomes bone, goes from peri, which means around, chondrium, the cartilage, to periosteum. It is from both of those tissues where cartilage gets more new cartilage cells and a bone gets new bone cells. When you have a broken bone, you will see it's the periosteum is where the healing occurs from. In surgery, I did a lot of bone surgery. You are so careful to incise the periosteum, reflect it, pull it to one side. We have a tool called the periosteal elevator. It's sort of a rounded kind of a way to pry it. So it hugs the bone. You can gently lift it up. Make sure it's out of the way. You don't want to sacrifice it or damage it if you can avoid it. Even if you get pieces of it, you save them because you can graft them directly on to reinforce it. And then whatever you do to the bone, you break it, you put wires, plates, pins, whatever the heck you put in there. You cover it neatly with a periosteum. You try to put it back the way we would phrase it in an operative report. We close it from deep to superficial in an anatomical fashion, including periosteum and capsule, subcutaneous, and skin, and define what kind of sutures. That's how you read a thing called an operative. You do them for so long, it's mechanical. They come out. Okay, so the resist, they have an opening for nutrient delivery, and eventually that opening will be what we call the nutrient foramina. A foramina is a little opening. We'll get into that. Made up of chondrocytes, again, the lacunae, the matrix, jelly-like is a good way. It's semi-solid, not solid. We learned about this, the hyaline. The fact that it's in joints is because it comes from the bones. You'll see there are other bones that grow differently. They develop within fibrous layers. It's very hard to explain. It's just a developmental process. Your skull. Those bones don't come from a cartilage shell. They start differently. They start in fibrous tissue that condenses, and you'll see it's called intramembranous bone. Between membranes of fibrous or connective tissue, and bone magically appears. And thankfully, your brain is encased in it. Your sternum, things like that, as you will see. And there's the elastic and the fibrocartilage we'll get into with time. So other than that, other than being bones and joints, ribs, so respiratory structures, ribs, larynx, nasal, and they give you a nice illustration. You see this a number of times. We're going to look at the bones. This is really our study of the cartilage, but we don't want to. You can flip back to that. Appositional and interstitial. Appositional, okay, basically think widening in shape, interstitial elongation. We use the same two terms for both. So when your bones are growing and elongating as you go through growth spurts, or you did, it was interstitial growth. And yes, there was always appositional growth. Because bone forms based on the forces that are on. If I had, or if you had, and all of a sudden we were in a contracted position for a stroke like this, would straighten it out. Eventually your joints would form, your bone would form. And you'd have to break them and reset them to try to straighten it out. Very famous, it's called Wolff's Law. It just means that bone grows and changes to the forces that are upon it. Not only is this, like for instance, somebody has a stroke, they have to drop it. Usually put a brace on it. It drops, not only will the soft tissues adapt to that, it's friction, sometimes surgically, but the bones eventually, all the joints will form. Now you're having to go in there, break them, reset them, fuse the foot, be able to do something. Love this stuff. It's not that boring. You got to stop keeping those late hours at night. Used to joke with the class, they probably found my daughter at some party. Her husband coaches a junior's the wrong term. One of the local youth, the higher level, probably like high school kids, elite hockey. And they travel everywhere close. Yeah, I mentioned he graduated from a place that you heard of called RMU back in 2005. I mentioned he was drafted by the Penguins. Played hockey in 2000, graduated in 2000. He's a really good skater. Never played at the minor league level, maybe never made it to the bigs, but he knows a lot of them very well. Because they were all played in those minor league camps and things together. He coaches and trains around here. It's the closest my daughter got to college. I used to joke, my younger two, my younger son and my daughter, the only time they got to college was for parties. God, you guys are no fun at all. It's all right. My eldest made up for it with parties in college. Calcification of cartilage during normal bone growth in youth, but it can occur in old age. So what happens is things like your cartilage between your sternum and your ribs becomes bone. That's not good. That's why because there's stretch. I mentioned that before. What does bone do? Supports, protects, something to hang on to, mineral reservoir all the times that are there. So all of these are very, very important that are there. And then we get to this. We don't spend a lot of time with it here. It's more of a physiological phenomenon. I have to mention it. The bone marrow, which is this cavity inside, technically, even though it's not necessarily making the red blood cells, a structure within the framework of the bones is making red blood cells and other blood cells. I beg your pardon for misspeaking. All blood cells. The way you pronounce that is hematopoiesis. And fat storage, people say, oh, I'm on a diet, my bones are going to get thinner. No. There's a nominal amount of fat. You very, very rarely, other than in starvation, would have occasion for that kind of fat to ever be utilized metabolically. What happens when the bone marrow is no longer doing hematopoiesis, it is filled with fat. Most of us in adults, there's only a few areas where we still do hematopoiesis, and it's basically, it's flat bones. Your sternum, you're going to learn the iliac crest. Put your hands on your hips, that area. That's there. Upper portions of the shoulder assembly, upper portion of the hip assembly. That's where you do bone formation as adults. One of the big problems with fat storage, and we'll talk about this in fractures, is large bones release fat into the bloodstream. And if it's a sufficient amount of fat, it can cause a blood clot just like any other blood clot. It's called a fat embolus. It's something you have to be very, very worried about. Treating big fractures. When someone comes in with fractured hip, fractured tibia, fractured femur, humerus, you start worried about things like that. And yes, it also has an endocrine function, which means to produce hormones. And as you can see, this osteocalcin has some role in the insulin and glucose levels and metabolism. Not something we're going to dwell on until we get to endocrine, but you can see there's a lot of roles. This is our part for lab. There are 206 bones. It's not like how many bones there are, but and this is the way to remember it. First you divide, your bone compartmentalizes. We're going to study axial, then we're going to study appendicular. Again, by definition, appendicular, the appendages are include also the connectors, the shoulder and hip assembly, even though they go all the way to here. Like the sternoclavicular joint, this is the one place where your upper extremity, you can feel it as you move this around. You can feel that bump over there moving. That's the one connection your whole upper extremity has to your axial skeleton. Your lower extremity, much better anchored by a famous joint called the sacroiliac joint, which we're going to learn about. There's two mated surfaces that look like ears on the sacrum, big bone where the connection is. That's part of your vertebral column. And the aforementioned ilium, one of the three bones that make up your hip assembly, and big surface area, very stable. Limited surface area, very mobile. Upper extremities are about what? Mobility. Lower extremities are about stability. You can study, I can't tell you what the best way for you to study or learn this stuff. I'm just telling you what works for me. If it helps you, good. If you use something totally different, I'm happy with it, just as long as you get it. My job is to make sure that you get it or try. Obviously, I can't study for you, but I can try to help you anywhere else. Appendicular appendages, plus they call them girdles. You'll learn the terms. This upper one, the shoulder assembly, another name is the pectoral girdle. Most people work out, they know where their pectoral area is. They know where their lumbar area is. The other one, the appendicular, we call the pelvic girdle. So those are names, and that's fair game on exam, so be familiar with it. You're already writing that down, underlining, highlighting. So you should be. Lou, can you tell them it's on the test? It's probably on the test. Be happy the Steelers won. I'm in a good mood. I may not be in a good mood next time. Never can tell. Pesky Seahawks. I'll tell you who did stink up the joint. They're already calling. If you're like me, I read the New York sports papers. Russ, goodbye. Put in Jackson Dart. We knew Fields was going to be a good. He's got a lot of resources. Russ has passed his best by date. One trick pony, that long moon ball. One trick pony. There's even a fight on the sideline between their really good receiver, Giants, and the coach. I mean, they were not physical, but they were not exchanging Christmas cards, let's say. Here's that same illustration again. Long bones has nothing to do with length. It's all bones are about shape. So you got a long bone. Okay, Lou, I'll look at the longest and strongest bone in your body. Femur. Multiply by 40 actually. Height. That's there. That's the femur. It's longer than this wide. Let's pick a teeny tiny one. The distal phalanx of the real bones. Distal phalanx of the pinky. It's longer than it's wide. I know it's not very long, but by definition, it's a long bone. Your extremity bones, most of the long bones would be accepted with the wrist, the ankle, and for the most part. So that's an easy guess to go with long bones to the knee. Short bones, the aforementioned wrist and ankle bones, aren't so much short, it has to do with their shape. Okay? They're sort of cubic shape. These are the wrist ones, there are 8. You learn the names, there's an easy mnemonic. There's a way we do it with letters to learn the names. We'll do that next week. Okay. Cubic is a good way to describe it. The hard part about these bones, whether they're here or a plastic model of the foot, these are a little bit larger, they're easier to know. See, calcaneus, your bone, talus, true ankle bone, tibia and fibula sit on that. This is called the navicular, this is kind of the highest one that's here. And you have this is called the cuboid. Those big 4 are tremendous angular. These little guys are called cuneiform. We'll get to all that. The trouble is, they're square or cubic, and they've got cartilage on both sides. The trouble is, if they're fractured, and it interrupts the blood supply, the cartilage starts to die. It doesn't have a direct blood supply. But what happens to cartilage when it gets blood or it's not getting blood supply? Here it's not replaced by bone. It's a very interesting product, reason for sport-related reason called avascular necrosis. Death of tissue from lack of blood supply. And bone, arguably the best two-sport athlete, better than Deion Sanders, that I have ever seen. And there's some really good ones historically. There's a guy named Bo Jackson from Harvard University. Go back and look. When you're the MVP, you're the best college player in the country, you're MVP in baseball all-star game. Pretty good one. And an innocuous hit out of bounds. That who gave him a hit. They dislocated his hip. Maybe you'll see on some of these hips. The blood supply to the head of the femur is through this little opening, through the fovea capitis severus. The little fovea or opening in the head capitis of the femur. We basically got a ligament that's in there, blood supply is in it, it's severed. jumped it out of the picture. It's pretty unusual for a doctor to say. He just looked around a little bit. He died. And I didn't. Replacement surgery very well. Another guy who just died in the last year, perhaps the greatest college basketball player I've seen. Kareem Abdul-Jabbar, Flew Alcindor, went to UCLA. They were, by the way, they couldn't play freshmen. He's winning 3 national championships, and they won like 6 national championships. UCLA back then. He was replaced by a guy who just died. Oh, don't forget his name. Oh. I'm having a moment. Nevertheless, I'm probably constantly about telling kids to Google it. Okay? Bill Walton. I'm not losing. You get to be this age, if you start to forget things, it can be contagious. It's all right. If you get an email from A.M. Stein, the military thing is don't answer. No, it's just not. Okay. It's a long process. Bill, he took over. I mean, he hit like 19 out of 20, won the championship games. He won when he was very young, he won an MVP of Portland. He broke the navicular bone, he died of gastroenteritis. I knew some of the doctors who treated him. They couldn't fix it. His foot was horrible, he couldn't get weight on it. He got better about 9 years later, and he was won 6 Man of the Year with the Celtics when they won the championship. Remember, he was healthy, he had a team that was like he was the championship. He was that good. 6'11", 7 feet, shoot the eyes out of it, great rebound, you name it. The Suns, one of the Suns, Luke Walton, was really great. Probably Kobe years. That's why I'm a sportsaholic with a long history of sports stuff. I remember a lot of it. So the kneecap is a sesamoid bone. The sesamoid bone, by definition, grows in a muscle or a tendon. The kneecap grows in a tendon with no extensible color. They're like little fulcrums. This bone here, the anatomist, it looks like a little P. We're going to get to it. It's called the pisiform, P-I-S-I-F-O-R-M. It forms in a little tendon. It's not really directly attached to these other bones, okay? But just because the tendon still rubs against it a little bit. So that's real bones. How do I know it's real? If they have color like this, if you look at them on the interior, and they really go down real fast. You see the little nooks and crannies. As opposed to this is your real bone, you can see it deteriorate. Dr. Dress was a partnership that I started here in 08. And I asked him, because I was doing most of the labs. Apparently, they decided to go in this direction, how to get bones from some university to sell those bones. They do one. These were already beat up. And they just tried to supplement it as much as possible. So, I mean, I can't say they're in great shape, but they're in okay. So, how do I know the plastic features? They have a lot of the features, but they're clearly plastic. So many old skeletons everywhere. Not with the blood hinge. Stranger in a strange land. Flat bones. The bones of your skull. Flat, again, thin, flat, and slightly curved. Breastbone, sternum, scapula, ribs and reading like the wrist. You do have skull fragments. These are flat bones. It's a child's. So gently curved, you can think of the rib. The sterna are really bad. just remnants of that. And I have a plastic model for sternum for the attached ribs, which I'll find. I did go out hunting it today. I did it anyway, so you can see some of those things that are considered flat bones. So we'll be, and most of the bones in the skull, which we have to do with, typically with models, hoping to find them today. Pulled out as many as I could find. See, but since Dr. It was people were doing this. I don't do this. And now I just do this once a year. Oh, I'll be unhappy if I don't find it, but I'll find it. And irregular bones. The best way for an irregular bone, I beg your pardon, is something that doesn't fit. And so the two classic examples of that are the hip bone, 3 bones in one. They're all fused together, have great big sockets, and fancy names called the abdomen. This is the ilium. I was talking all about the ilium before. So how do you know which is which? I don't do right. That. It's not hard to figure out. We know that the femur is going to fit in there, so it's got to go on the outside. We know if you're sitting down here, it's going to be too far. No, that's exterior. So you have the ilium, here's the crest, here's the ribs. This is the ischium, the thicker, wider part back here. They all contribute to this small area called the pubis. Ilium, ischium, pubis joined in the ass. So that's the irregular shaped bone. And the classic irregular shaped bones are vertebrae. What is it all for lunch? Here, say lumbar vertebrae. How do I know it's lumbar? This is called the spinous process, where we derive the name spine. So the spinous process protrudes posteriorly, and in doing so, tells us to sort of gives an idea. They're kind of large, hold them like that. And there's other ways you can tell from what these are called sets. These other processes, spinous process, transverse process. This is the body. You can see in there that opening, and even the shape of the opening is you know. But the best thing of the spinous process is that we'll see if I can find it. Here's that sternum classic model. So you can't bend them, but you know how the doctor checks your spine for scoliosis, and so they have you bend over like that. And what happens is these protrude. Ones that are easy to feel, the thoracic area, you can see the spinous process is sharp to the side. You see that? These go to the lumbar, 5, 4, 3, 2, 1. Even this would come over, you see the angle down there, that's thoracic. When you get up here, we'll show you a way to identify cervical or small. As soon as I find some to show you. And the sacrum, you can see, is this is all fused, it's all 5 fused together. Those are that roughened area that look like little ears, are called auricular surfaces. And they're designed. There's your sacral isoscale. So my father, what movie was that? That's Princess Bride. So you'll see when you leave here very often, I'll tell you, have fun storming the castle. Princess Bride. Andy Patinkin in a very memorable role. One of my favorites. So my daughter would have it. My daughter is 40, so she was born, that was in 1987. That was produced by Rob Reiner, whose dad, Carl Reiner, and Mel Brooks, formed one of the early comedy duos called the 2,000-Year-Old Man. And so that was Mel Brooks' studios produced that at the time. He did a lot of movies at that time, but Rob Reiner was basically the creative juice behind that brilliant movie. And it introduced us to a lot of interesting people who had very long and illustrious careers. That was not a great sword fight. You have to go back to the days of Earl Flint, Robin Hood, Captain Blood, back in those days. He fought a guy named Basil Rathbone. Rathbone had a very good career playing Sherlock Holmes, one of the more definitive Holmes, back in the 40s. And he was a very proper British guy. He won in his whole career sword fights. He only won two. World War I, world history. He was the brigade champion for one of the British armies. Short sword. He was undefeated in the army, but he never fought well. Broken crazy. These wonderful sword fights. I lose. So as you're telling, I have a love for old movies, among my other interests. Keeps me out of trouble. No. So here we are. We're not doing this. We're not going to look at Spongy. That's lecture. This is a really good illustration of what we call these trabecular bone. It's in both. This is a flat bone, for instance. What's unique about that is and this prevents you hit on the head with an object or in a fight. That really it insulates you, so they absorb a lot of the shock. But it's a honeycomb. All the thing of that is all surface for blood formation. That's there. So not that we would sample it in the skull, drill a hole in somebody's head for something like that. Typically, when you want to do a sample to see how the bone marrow is working, you use you do bone marrow transplants or bone marrow assays. You use easy access that's not going to hurt somebody or look unsightly. So you're going to use the sternum or you're going to use the iliac crest. So we used to see those were done at bedside pretty routinely back in the day. Now they probably do them in not even a short procedure. They'll do them in different areas. When I was getting blood transfusions at St. Margaret's Hospital in Aspinwall, they call it the medical unit. Basically, they did liver biopsies, those kind of those kind of bone biopsies there, as well as give a lot of transfusion and chemotherapy. So we'll get into all that. That's lecture, the whole structure, all those things are there. I'm going to grab a break anyway in a few minutes because my voice is not going to last. Why don't we do that now? Because my voice is not going to last. That gentleman had to go. It's 4 o'clock. And give me 10 minutes. So we'll meet at 4:12. Work? Good. Good here.